Hi folks, this is Dr. Patil here, and this is the video module where we will be discussing about overlap syndromes. The moment I say overlap syndromes, the first thing that comes to mind is mixed connective tissue disorder, right? But we have to also understand that mixed connective tissue disorders and overlap syndromes are not one and the same. They are not synonymous, right? The overlap syndrome is a broader umbrella term under which mixed connective tissue disorder is one of the overlap syndromes, right? So first, let us clarify what is overlap syndrome. Overlap syndrome usually refers to an entity where patient shares characteristic features of more than one autoimmune connective tissue disorders, right? So what are the autoimmune connective tissue disorders? We know, broadly speaking, there are 5 major class of autoimmune connective tissue disorders. The first one is our SLE, right? Then the second in the list is our rheumatoid arthritis. Third in the list is systemic sclerosis. Then we have Sjogren's syndrome, right? And last but equally important, we also have our idiopathic inflammatory myositis, or what we currently call as inflammatory muscle disease, or if you want to call them as immune mediated muscle diseases, well, fair. So that mainly includes our dermatomyositis and polymyositis, which are frequently part of the overlap syndromes, right? So these are all our immune mediated connective tissue disorders. We also recognize some inherited non-immune mediated connective tissue disorders like Ehlers-Danlos syndrome or other collagen disorders, right? Those are connective tissue disorders, but they don't have a immune pathology there, right? So overlap syndrome is basically a combination of multiple of these clinical features, right? So for example, if a patient has SLE-like features plus he has also clinical features of rheumatoid arthritis, then we currently call it as rufus, right? So rufus is also one of the overlap syndrome, right? Okay. So mixed connective tissue disorder is one of those overlap syndrome which has certain peculiar clinical characteristics and certain peculiar serological features. That is why we discuss it as a separate entity, and this would be our primary focus today, because if at all they're asking questions from overlap syndromes, most likely it will be about the mixed connective tissue disorder, right? Clear? Okay. Now apart from this mixed connective tissue disorder, there is one more entity. The terminology is also important for us, that is UCTD. UCTD stands for unclassified or undifferentiated connective tissue disorder. Now, what is an undifferentiated connective tissue disorder? It is a patient who has some clinical features of the connective tissue disorders, but the clinical features do not peculiarly fit into the picture of any one of these 5 entities. There is no overlap as of now, right? When I say overlap syndrome, that means clearly we have some SLE features, some RA features, or some SSC features. There is overlap of these features, right? In undifferentiated CTDs, we cannot clearly ascribe one entity to these patients' symptoms or complaints, right? That is what we call as undifferentiated CTD. This is not a overlap syndrome per se, right? And we have to also understand that undifferentiated CTDs, most of them eventually evolve into one of the full-blown pictures, right? So initially, or as of now, this case may be classified as UCTD. Few years down the line, it might evolve into systemic sclerosis. It might evolve into SLE, or it might evolve into rheumatoid arthritis or something like that, right? And it might even remain undifferentiated throughout the course of the illness. That is also a possibility, right? Clear? Now, before we go to the MCTD, there are some important MCQ points to address here. The first MCQ point is, what is the most common component of these 5 immune disorders, most common component of overlap syndromes? Right? So the answer for that is Sjogren's. So Sjogren is the commonest component of many of these overlap syndromes. Sjogren's is the most common. The second most common is actually your systemic sclerosis. Second most common is your scleroderma or systemic sclerosis. Clear? Okay. Now, after this basic understanding of the overlap syndromes, let us talk about the mixed connective tissue disorder. Now, in the very beginning of the session, I told you that mixed connective tissue disorder has certain peculiar clinical characteristics and peculiar serological characteristics. So, let us understand what do I mean by that, right? So, mixed connective tissue disorder is a overlap syndrome where patients are having overlap of 4 important connective tissue disorders, overlap of 4 features, 4 disorders. One is our SLE. The second one is our rheumatoid arthritis. The third one is systemic sclerosis. And the fourth one is inflammatory muscle disease. It's mostly about polymyositis. Not the dermatomyositis, most likely it is polymyositis. So patients are sharing the clinical characteristics of systemic sclerosis, SLE, rheumatoid arthritis, and inflammatory muscle disease. Apart from that, they are usually positive for a antibody known as anti-U1 RNP antibodies, right? So when you have this characteristic combination of 4 autoimmune rheumatological disorders, clinical features of all of them, SLE, SSC, RA and IMD, plus the antibody which is U1 RNP antibody, that is what qualifies to be called as mixed connective tissue disorder. So this antibody is very characteristic of it, not specific, we will discuss more about it, but it is characteristic of it, right? And this mixed connective tissue disorders also share an important genetic risk or genetic characteristic. The characteristic is they usually have HLA DR9. So HLA DR9 is a risk factor for patients to develop mixed connective tissue disorder, right? Sorted. Now, coming to the clinical features of mixed connective tissue disorder. The usual age of presentation of these patients is around 35 to 40 years. 35 to 40 years. And there is a clear-cut female preponderance. Female to male ratio is usually in the range of 15:1. Very classical clear-cut female preponderance, and it is the middle-aged women who are most likely affected, right? It is not the typical very young adolescent or the 20s or 30s. It is like 35 to 40 is the usual age range, and females are more likely affected than males. Okay, if you ask me what is the most common clinical manifestation of mixed connective tissue disorder, we have already discussed these 4 entities, so it has to be one of the clinical features of these 4 entities, right? These 4 of these connective tissue disorders. So what is that? The most common manifestation is usually Raynaud's phenomenon, right? It is usually Raynaud's phenomenon. This is seen in more than 90% of the patients who eventually get diagnosed as mixed connective tissue disorder. It is seen more than 90% of the patients. And obviously, when we are talking about Raynaud's phenomenon, here it is secondary Raynaud's phenomenon. It is not the primary, right? It is secondary RP. So obviously, it will be associated with abnormal nail fold capillaroscopy. Abnormal NFC findings would be there, right? Clear? So this is the most common manifestation. This is the one of the important MCQ point. Okay, this has been asked multiple times in the past. Now coming to the second most common manifestation. The second most common manifestation is synovitis and polyarthritis, right? Am I making it clear? Synovitis and polyarthritis is the second most common manifestation. Okay, now when I say arthritis, obviously we are talking about either SLE-like arthritis or RA-like arthritis, right? So that again begs the question, is it going to be erosive or is it going to be non-erosive, right? So this is one more point we should be aware about. It is polyarthritis, right? It is most likely erosive. So up to 50% of the patients have erosive polyarthritis. So the patients are prone to develop joint deformities like you see in patients with rheumatoid arthritis, right? Up to 50% have erosive. Remainder may have non-erosive, right? Clear? At the time of presentation, up to 50% have erosive polyarthritis. Okay. Now, apart from this arthritis, these patients are also known to develop inflammatory myositis. So that was also one of our component, right? IMD is also one of our component. So here I have already told you, most likely you are expecting a polymyositis picture rather than the dermatomyositis. So you are not seeing those characteristic skin rashes in these patients. It is mostly polymyositis. Clear? Okay. Now coming to the pulmonary manifestations. Pulmonary system is frequently involved, and the most common pulmonary manifestation is usually your interstitial lung disease. The interstitial lung disease that we see in patients with the MCTD are usually of 3 types. The most common among them being non-specific interstitial pneumonia. The second most common is usually your usual interstitial pneumonia, and the third most common, otherwise you can say the rarest form, they can have lymphocytic interstitial pneumonia. So these 3 types of ILDs are known to occur, NSIP being the most common, right? So again, one more important point, is it the common cause for death? The answer is no. When we talk about systemic sclerosis generally, we do say that ILD is the most common cause of death. But in these patients, it is the pulmonary arterial hypertension which is the most common cause of death, right? Is that clear? Okay, so lung-wise, we can have the ILD. Cardiovascular system involvement. The most common cardiovascular manifestation is indeed pulmonary arterial hypertension. Pulmonary arterial hypertension, and this is the most common cause of death. Most common cause of death. right? So the pulmonary arterial hypertension, depending on the method used for the diagnosis, whether you are following the right heart catheterization or whether you are following the echo characteristics, you might have varying prevalence being reported. I think the same thing also holds good with respect to ILD. If you are looking at the clinically evident ILD, patients having dyspnea or symptoms of ILD, then it is seen in up to 40 to 50% of the patients. But if you do the screening CT scans, right, you might see more than 78% of patients of MCTD having some degree of radiological ILD, right? So CT evidence of ILD, though clinically they may not have any manifestations as such. Okay, clear? So ILD and pulmonary arterial hypertension are important comorbidities that we see in these patients. Okay, now coming to the skin manifestations. The skin manifestations, obviously, I'm not expecting them to have the characteristic diagnostic dermatomyositis rashes, because mostly the myositis that we see in these patients is polymyositis type, right? So mostly if you're talking about skin manifestations, it is all about our Raynaud's phenomenon and its consequences or its sequelae, right? So if you examine these patients, you might notice puffy fingers and hands. So it is usually because of the edema. This is different from sclerodactyly. Patients might have sclerodactyly. This is also different from what we call as dactylitis. In dactylitis, you will notice that there is a uniform swelling of the fingers, unlike the kind of swelling we are noticing here. It will be like as if there are two parallel lines. The whole finger is uniformly swollen. That is what we call as dactylitis, right? That is usually seen in patients with psoriatic arthritis or sickle cell anemia and some infections. Okay. Then we also see fusiform swellings whenever you have, because of the synovitis, whenever you have rheumatoid arthritis. The affected joints might show fusiform swelling with your interphalangeal, this phalanxes being normal, right? Only the interphalangeal joints might show, the proximal interphalangeal joints and the metacarpophalangeal joints might show fusiform swelling in a patient with rheumatoid arthritis. Here there is diffuse edema of the hands and fingers. That is what often described as puffy fingers and hands. That you might see, and apart from that, you might see certain sequelae of Raynaud's phenomenon. Because this is a secondary Raynaud's phenomenon, there is clear-cut vascular injury, there is vascular pathology. So patients are prone to develop digital ulcers like you are noticing in this image, and these microvascular injuries might heal with scarring. So you might see such pitted scars on the pulp spaces of the finger, right? So cutaneous wise, puffy fingers and hands and sequelae of Raynaud's phenomenon. This is what we are expecting. Now coming to further manifestations, in terms of GIT involvement, esophagus is the most commonly affected organ, and the most common manifestation in esophagus is GERD. This is because of the relaxation of the lower esophageal sphincter. GERD is the most common GIT manifestation of the mixed connective tissue disorder. Apart from that, patients might have, okay, as I've already told you, this is most common. Apart from, patients might have esophageal dysmotility, varying degree of esophageal dysmotility, and patients are also prone to develop, I'm talking about GITs, patients are also prone to develop pneumatosis intestinalis. One more feature shared by our systemic sclerosis, right? This can also occur in patients with systemic sclerosis. So these are the three important GIT manifestations: GERD and esophageal dysmotility with respect to esophagus, and that is the most commonly affected part of the GIT. And if you go further down, intestines may be affected in the form of pneumatosis intestinalis. Clear? Okay. Now, one characteristic statement that we see in the standard textbooks of medicine is that there is no neurological or renal involvement in patients with MCTD, which is largely true, because we are talking about some disorders which are characteristically known to cause significant neurological dysfunction. For example, SLE. Patients can have cognitive decline, patients can have neuropsychiatric manifestations. Those are extremely rare in patients with MCTD, right? Similarly, renal. SLE is very notorious to cause the proliferative form of lupus nephritis, like that is also rare in patients with MCTD. So if you take into account these factors, then this statement, generalized statement, makes sense. There is no renal and CNS involvement in patients with MCTD. It makes sense, right? So if at all, if you see such a statement, it is a true statement, right? It can be called as a true statement. But if you look detailed, you might find that patients of mixed connective tissue disorder may develop neurological manifestation. They may have renal manifestations. So what is the most common neurological manifestation? The most common neurological manifestation is trigeminal neuralgia, trigeminal neuropathy. Trigeminal neuralgia, that is the most common neurological manifestation. Okay. And what is the most common renal manifestation? The most common renal manifestation is usually membranous glomerulonephritis. Membranous glomerulonephritis. So obviously it is not a proliferative form, right? So there is no major severe involvement of kidneys. There is no severe involvement of the brain. That much I can clearly tell you. Okay. Now moving further, if you look at the investigations that are done for a patient with mixed connective tissue disorder, what are we expecting? So in mixed connective tissue disorder, the first and the most important thing we have to understand is 100% of these patients have ANA positivity. 100% of these patients have ANA positivity. And the ANA is usually high titer. And if you look at the ANA pattern, which is also particularly important from the perspective of MCQs, we usually see coarse speckled pattern. Coarse speckled pattern. Right? So there is a entire nucleosome which is stained with coarse speckles like you are noticing in this image, right? For more details about the ANA pattern, please watch my video on the ANA pattern, right? That is important, that you might get one MCQ from that side. Okay, so you see coarse speckled pattern of ANA in these patients. What other conditions you might see coarse speckled pattern? Okay, the coarse speckled pattern can also be seen when you have antihistone antibodies, right? You might see with antihistone antibodies. You might also see coarse speckled pattern with anti-RNA polymerase 3 antibodies, with anti-RNA polymerase 3 antibodies, right? So anti-U1 RNP, antihistone and anti-RNA polymerase 3 antibodies usually cause this coarse speckled ANA pattern. Okay, is that clear? So ANA is 100% positive in these patients, and these patients have this characteristic ANA antibody called as anti-U1 RNP antibody, which is seen in more than 90% of the patients who are eventually diagnosed as MCTD. But we have to also understand that this is not specific. It can be seen in SLE, rheumatoid arthritis, systemic sclerosis in the absence of the shared features. So when there are shared features, yes, it is MCTD, but in the absence of shared features, you might see the anti-U1 RNP antibodies. But there are few things which might prompt you to clearly rule out MCTD when you have an SLE patient, because in SLE, when you see anti-U1 RNP antibodies, if there are no shared features, most likely this U1 RNP antibody in SLE is likely to be IgM type, and often the titers are low. And in case of MCTD, this antibody is mostly IgG type and the titers are high, right? It often has high titers. Okay, clear? Now with this background, let us go to the classification criteria. Now, unlike our SLE and unlike our rheumatoid arthritis, there is no one single established classification criteria. Most of these cases are reported from Japan, and probably most of the criteria also come from the Japanese soil. Okay, so the first criteria that was proposed, the first description of MCTD come from the team called as Sharp and Team Sharp et al. Those criteria were proposed in, I think, 1987, and since then there are many other classification criteria proposed. Now these are the three classification criteria which most of the standard textbooks score. One is Alarcon-Segovia, second one is Kahn and Applebaum, and the third one is Kasukawa. As I've told you, most aggressive work on these disorders are occurring from the Japanese soil. So probably I would personally go with the Japanese classification criteria. And in fact, studies also agree the Kasukawa classification criteria has the highest sensitivity among the three that I just spoke about. Highest sensitivity, right? Unlikely that they will ask a question on this, but still we should be aware about it. Kasukawa has the highest sensitivity. Okay. Now let us look at all of these. The first thing we are talking about is Alarcon-Segovia. In Alarcon-Segovia diagnostic criteria, there are two domains. One is serological criteria and the second one is clinical criteria. The serological criteria is specifically looking at the anti-U1 RNP antibodies using a hemoagglutination titer. So the anti-U1 RNP should be positive, and apart from being positive, the titer should be more than 1:1600. So 1 in 1600 is the minimum titer that we are expecting. Right? Clear? And this number differs for different criteria. Okay, so this should be positive, and in presence of anti-U1 RNP antibodies, patient should satisfy 3 out of these 5 clinical criteria. 3 out of these 5 clinical criteria. So what are these? One is edema of the hand. We were discussing about it when we discussed the cutaneous manifestation, right? Edema of the hand. Then synovitis. Synovitis is the second most common clinical manifestation after the Raynaud's phenomenon, right? Okay. Then myositis, Raynaud's phenomenon and acrosclerosis. So 3 out of these 5 should be present, and among these 3, one should be from either synovitis or myositis. So in the absence of synovitis or myositis, we cannot classify a case as MCTD according to Alarcon or Segovia criteria, right? So either synovitis or myositis should be there. So this is frozen. 1 out of these 2 should be there, and among the remaining 3, 2 out of the remaining 3 should be there. Okay? Then you can classify it as MCTD according to Alarcon and Segovia criteria. So to give you a summary, serology should be positive with the titer of 1 in 1600. 3 out of 5 clinical criteria should be there, and out of these 3, at least 1 should be about synovitis or myositis. Okay. Now the next classification criteria is Kahn and Appelbaum criteria. So according to this Kahn and Appelbaum criteria, the anti-U1 RNP titer should be more than 1 in 1200. So in the previous criteria it was 1 in 1600. Here it is 1 in 1200 in a patient with ANA titer. So ANA is also quantified here. In a patient with ANA titer more than or equal to 1 in 2560 and a speckled pattern of ANA. So on the IF pattern it should be speckled. Okay, so this is the serological criteria. So serology should be there. Serological criteria satisfied. Then we are looking at the clinical characteristics. So what are the clinical characteristics listed here? The Raynaud's phenomenon is kind of mandatory, right? So patient should have 3 or more than 3 clinical characteristics. Out of that, Raynaud's phenomenon is mandatory. Just like how in the previous criteria we had either synovitis or myositis should be mandatorily be there. Here it is Raynaud's phenomenon. Raynaud's phenomenon should mandatorily be there. So that satisfies one clinical domain. Now we need 2 more. So among these 3, swollen fingers, synovitis and myositis, among these 3, 2 out of these 3 should be present, plus your Raynaud's phenomenon should be present, plus your U1 RNP titer of more than 1 is to 1200 should be present in a patient who is already having ANA speckled pattern with a titer of 1 is to 2560. That would classify the case as MCTD. Clear? This is our Kahn and Appelbaum criteria. Now coming to the most sensitive criteria. The most sensitive is our Kasukawa criteria. Okay, so in Kasukawa criteria, we have something called as common symptoms. So one of the common symptoms should be present. What are the common symptoms? Either Raynaud's phenomenon or your puffy fingers and hands, your swollen fingers and hands, or your Raynaud's phenomenon. One of these 2 should be present. Among the common symptoms, 1 should be present, and patient should have the anti-U1 RNP antibody positive. So serology should be present, right? Plus you are looking at 3 clinical domains or 3 CTD features, and among these 3 CTD features, patient should have at least 2 of these 3 CTD like entities, and under these 3 CTD like entities we have defined clinical parameters. So at least 1 out of these parameters, at least 1 of these or more than one of these parameters should be present to say that it satisfies these clinical entities, right? So let us look at each of them. SLE-like syndromes, SLE-like symptoms, polyarthritis, lymphadenopathy, facial edema, pericarditis, pleuritis, or leukopenia or thrombocytopenia, right? If any one of these is present, then you would say that SLE-like symptoms are present. That would satisfy one clinical domain, right? Now, the systemic sclerosis-like findings like sclerodactyly, pulmonary fibrosis, restrictive lung picture, or reduced DLCO, right, or hypomotility or dilation of esophagus. Right? If any one of this or more than one of this is present, that would satisfy the SSC-like findings, right? And the polymyositis-like findings. I've already told you when we talk about myositis here, it is about polymyositis, not about dermatomyositis. So muscle weakness, elevated CPK levels, or the myogenic pattern on the EMG. If any one of these is present, that satisfies the PM-like findings. So what is required in Kasukawa criteria for the diagnosis of MCTD is patient should first satisfy one of the 2 common symptoms, right? One of the 2 common symptoms. So patient should either have Raynaud's phenomenon or have swollen fingers and hands, right? Swollen fingers or hands. Plus, after this, patient should be positive for anti-U1 RNP antibody, right? Plus, patient should have 2 out of these 3 CTD-like features, 3 CTD-like entities, which is our SLE-like symptoms or SSC-like symptoms or PM-like symptoms. And we would say that it satisfies this SLE-like symptoms or SSC-like findings or PM-like findings when one or more than one of these features are present, right? One or more than one of these clinical findings are present for SLE, for systemic sclerosis, for CM. That would satisfy the criteria to call the patient as having mixed connective tissue disorder, right? Okay. Now that completes our diagnosis. Now coming to the management of mixed connective tissue disorder. We have to understand that this is a condition where there are overlap of many features. So most likely how we treat these patients is try to treat the dominant entity. That is one approach, and try to treat the individual symptoms. For example, Raynaud's phenomenon is a very common complaint, right? As such, most cases the dominant entity is systemic sclerosis. That's how some of these patients will evolve eventually into systemic sclerosis. So all the complications that you're expecting in systemic sclerosis, we should be aware about, and we should be monitoring these patients for that. For example, interstitial lung disease, pulmonary arterial hypertension. So a regular monitoring of echo, then frequent pulmonological assessment, and if required, a CT examination is considered mandatory, right? Similarly, patients are prone to develop digital ulcers and pitted scars and other complications of Raynaud's phenomenon. So treat Raynaud's phenomenon using the calcium channel blockers like nifedipine, right? So that would be one approach. Treat the complaints and try to treat the dominant manifestation, right? That is the usual approach. So mainly it is about symptomatic management, as I have already told you, right? So that includes your CCBs, mainly nifedipine or other DHP CCBs for your Raynaud's phenomenon. That is one. Then monitor for complications. Mainly for pulmonary arterial hypertension. If pulmonary arterial hypertension is present, treat it accordingly. Monitor for your risk of developing interstitial lung disease. If interstitial lung disease is diagnosed, treat it with pirfenidone or nintedanib, or if required, you might need to use the cyclophosphamide, right? So that would be our approach. So it is nothing specific here, right? So there is no specific target, what I should say. We don't have any specific target cytokine involved in the pathogenesis. Clear cut idea we don't have. So we cannot have a tailor-made approach for treatment. Right? There is no standard guidelines. Treat the disease behavior. The way the disease behavior, treat it accordingly. If it is behaving like systemic sclerosis, treat it like systemic sclerosis. If it is dominantly behaving like rheumatoid arthritis, if there are joint deformities appearing, then give the methotrexate to the patient. That would be the approach. Okay. Now coming to the prognosis of these patients. When it comes to prognosis, we have to understand that the most common cause of death is usually our pulmonary arterial hypertension. That is one point I wanted to remember from the exams perspective. And the second point you have to remember is that some of these MCTDs eventually evolve into other entities, right? So most commonly it evolves into 80% of the cases do not evolve, they remain as MCTDs. The 20% might evolve. Among them, the most commonly it evolves into systemic sclerosis. This is seen in around 17% of patients in one of the major studies from India. Okay. Then the second most common evolution is into SLE, and the third most common evolution is into your rheumatoid arthritis. So this is seen in less than 1.5% of the patients. Evolution into SLE is seen in around 9% of the patients. Okay. So that completes our basic understanding of the MCTD, mixed connective tissue disorder, and also a little bit of a quick overview of the overlap syndromes. Now, before we wind up, let us take a quick look at some of these important take-home messages, which are nothing but MCQ points. What is the most common component of these overlap syndromes? Sjogren's is the most common component. Systemic sclerosis is the second most common component, right? In MCTD, there is 100% ANA positive. That is one important point we should note. What pattern we are expecting? Coarse speckled pattern is what we are expecting, right? Coarse speckled pattern is what we are expecting. Then the most common cause of death in MCTD is usually pulmonary arterial hypertension. It is not ILD, because the most common ILD variant is NSIP, which is relatively mild, not a rapidly progressing entity, right? Okay. The most common clinical feature of MCTD is Raynaud's phenomenon. That is the first most common. Synovitis polyarthritis is the second most common clinical feature, right? MCTD most commonly evolves into, yes, systemic sclerosis is what most commonly MCTD evolves into. Evolution is not a rule. Majority of the cases remain as MCTD. They continue to have the shared features. But if at all it is evolving into something, it is SSC. That is the most common thing. Followed by SLE, followed by rheumatoid arthritis. Clear? Okay. So with that, I will be signing off, guys. Let me again connect with all of you with another important topic.